Assalamu alaikum and hello everyone. Good morning, good afternoon, good evening, wherever you are. My name is Dr. Muhammad Hatta and I am your moderator for tonight. I am also the treasurer for MSART, which is the Malaysian Society of ART for the term 2024 to 2026. And on behalf of MSART, I extend a warm welcome to all of you for joining us today in this webinar organized by Ferring Pharmaceutical. Now, a bit about MSART. MSART is a non-profit organization that represents Malaysian ART practitioners and allied health personnel in fertility practice. And since its establishment in 1993, MSART focuses on broadening towards providing common forum for ART practitioners to exchange ideas, research, and share knowledge towards betterment of fertility practice in this region. In line with this purpose, we are excited to share a diverse range of events lined up for you this year. One of the highlights of this year is our webinar series designed specifically for healthcare professionals, covering various fertility topics. And we will be having our annual conference on the 5th and 6th of October this year. And stay tuned for further announcements of our conference. Now, let me get to the agenda of today's meeting. We have today's webinar features two distinguished speakers. The first speaker will be Dr. Brian Levine, founding partner and practice director of CCRM Fertility of New York. And the second speaker is Professor Michel DeVos, Associate Professor in Reproductive Medicine and Senior Medical Director at the Center of Reproductive Medicine at UZ Brussel-VUB. Audience are encouraged to submit your questions in the Q&A box while the speakers deliver their respective lectures. We'll address them during the Q&A sessions at the end of the seminar. So the lecturers will give their lectures. This is after the second lecture, we'll follow by the Q&A session. Okay, without further ado, I'd like to invite Prof. Dr. Brian to proceed with his first lecture. Now, Dr. Brian, as I said, is a founding partner and practice director for CCRM Fertility of New York. He has many years experience in IVF, IUI, PCOS treatment, and many other areas as well. He is a board certified in reproductive. He is board certified in reproductive endocrinology and infertility in obstetrics and gynecology. And he leads the industry in normalizing open dialogue about fertility, a medical condition that affects, as you know, 1 in 8 couples. Over the years, Dr. Levine has cited as one of the nation's leading fertility experts in the New Yorker, New York Post, NBC, CNN, and Avenue Magazine, to name a few. And his offers valuable insights on everything from fertility misconception, egg freezing 101, and to how men can boost their fertility. With that, I welcome Dr. Brian. The floor is yours.
Thank you so very much, Dr. Hatta. It is truly a pleasure to speak with you this morning. It is 8 a.m. in New York City, where I'm coming to you from right now. And today I'm going to talk to you about a topic that I think is incredibly important and valid, because as I was watching the introduction to this conference, I realized we don't have access to drugs like Folotropin Delta. And so in the United States, we actually have very few medications that we can use. And so using luteinizing hormone, or LH activity, has truly become the backbone of our treatment in how we treat patients and trying to offer bespoke care. So today what I'm going to do for you is I'm going to take you through my lecture. Of course, my disclaimer is that I am being sponsored by Ferring Pharmaceutical to give this lecture, although I did make all these slides myself and had no assistance in doing so. And let's get into this. So one of the first things that I'd like to share with everyone is that I practice medicine every single day. I'm a clinician, I see patients, and as such, I I use luteinizing hormone in the form of Menopur. And so when I talk about Menopur to the group, you should understand that that is truly just a highly purified human menopausal gonadotropin, or HPHMG, as many of us will say. But to try to be consistent throughout the lecture, I'm going to just use the word Menopur, which of course is the Ferring product. I have a couple of goals for today, and I hope I'm able to achieve them with you. I will introduce Menopur and how its mechanism of action and how it differs from just straight luteinizing hormone. Explain how stimulation with Menopur differs from stimulation with recombinant FSH, which of course is one of the backbones of our treatment paradigms as well. We're going to review some clinical trial data showing the safety and the efficacy of Menopur in ovarian stimulation. And as you'll get to see, I get very excited about the research because the research truly supports my clinical decisions that I make. And then ultimately, we're going to discuss patient cases that can help facilitate the successful use of Menopur in clinical practice. So in the United States, it's important to understand that ART is on the rise. This is no different than where you are in Malaysia or Singapore or anywhere else around the world. Fertility is a problem. It's actually affecting 1 in 6 as per the World Health Organization. But to help you understand and orient to what I am seeing in the United States, we are seeing that the use of ART has increased by 50% between 2012 and 2021. In fact, in 2021, it was estimated that nearly 2.5% of all the infants in the United States were born conceived using ART. That was the result of a little over 400,000 cycles, and it ultimately resulted in 112,000 pregnancies. Of those pregnancies, 86,000 infants were conceived in 2021. The reason that there's a lag of the data, just so everyone's aware, is that in the United States, we do have to report to the government, and the government takes 2 years to digest that data and to release it. And the governmental body in the United States is the Center for Disease Control, who follows ART outcomes. So to understand what we do as doctors every single day in treating patients is I like to talk about the 6 facets or features of ovarian stimulation. It starts with ovarian stimulation, which is where we ultimately try to stimulate the ovaries to get eggs. It then moves on to a harvest or an egg retrieval. Then we move on to an insemination or fertilization technique. The embryos are then cultured in the laboratory for a set amount of time, and then a transfer occurs, and then ultimately a pregnancy test is after that. What we're going to focus on today is that first aspect here of the reproductive cycle, which is ovarian stimulation. To help refresh everyone's mind, but I know that this is what everyone does every single day as well, is that endogenous gonadotropins are involved in follicular development, selection, and ovulation. When we are treating patients as fertility doctors and practitioners, we always talk to our patients about the 3 phases that are within the menstrual cycle: the follicular phase, the ovulatory phase, and the luteal phase. And as we all know that throughout the cycle, FSH and LH continue to rise throughout this. Ultimately, estrogen goes up as well, and that happens all pre-ovulation. Now, we're focusing our talk today about optimizing stimulation and how we can use luteinizing hormone, or HCG, which we'll use synonymously in a little bit, to help improve our patients' outcomes. So it's important to focus here on the role of LH, or luteinizing hormone specifically. We know that LH may determine follicular fate earlier than people thought years ago, and that's directly related to the size of the follicle and the stage of the follicle. When the follicles are less than 5 millimeters, it's been found that there's no LH receptor expressed in the granulosa cells. However, when they start to grow between 5 and 10 millimeters, which is what you can detect on your transvaginal ultrasonography, we start to see that there's expression of the LH receptor in the granulosa cells of nearly 80% of the follicles. And by the time that we have a 10 millimeter follicle or greater, we know that there's expression of the LH receptor that is increased while the FSH receptors are decreasing. This is a key point for the lecture. If you take a look at serum hormone levels, we know that the pituitary HCG that is released mimics the LH activity. And ultimately, there's an important role for that. It promotes the recruitment and the selection of follicles. Your primordial follicles will ultimately, some will become primary follicles, some will then become secondary follicles, preantral, small antral, and then dominant. As we know, this is going to be FSH dependent, but is a requirement to have LH activity present. In fact, beautiful studies have been able to illustrate that low levels of pituitary HCG can mimic the pulsatile pattern of luteinizing hormone secretion. If you take a look at the slide on the left, this is a 39-year-old female in the follicular phase, where you're able to see that the red is the luteinizing hormone and the dark blue is the HCG. And then ultimately the curves can almost lay on top of each other. And then on the right, you see this in a 28-year-old female in her luteal phase, right? That second half of her cycle. And once again, there's beautiful overlap between the patterns of luteinizing hormone secretion and pituitary HCG. Now, pituitary HCGs also peak in parallel with the mid-cycle LH surge, that mid part, that ovulatory phase of the cycle that we discussed before. On the left, you're taking a look at the HCG peak levels, and on the right, you're looking at the LH peak levels. Don't be so concerned with the values itself, but more with the shape of the curve as a result of the surge that is occurring. Now, if we were to take a look at the actual biochemical structure and do a deep dive here, we know that luteinizing hormone and HCG are similar but different, right? We know that the alpha subunit is going to be conserved, and that happens in most of our anterior compartment pituitary hormones, but it's truly the beta subunit that's going to differentiate between the two for that carboxyl terminal peptide extension that we see here. It's also important to know that they are similar but different in the activation of the pathways that they signal downstream. Up here, we have a, if you can see my mouse here, we have a illustration of what the luteinizing hormone or the chorionic gonadotropin receptor looks like. And then ultimately, HCG and LH bind in distinct regions of this G protein coupled receptor. We then go on to see that those distinct regions result in activation of different pathways. Depending upon the ligand, the binding can have either steroidogenic, apoptotic, or anti-apoptotic or proliferative effects. And as fertility doctors, we hope to actually be able to hone in on the proliferative effects because we would like to have more follicles and better quality follicles as we proceed through stimulation. It's important to understand that the biochemical profile of luteinizing hormone and HCG are different. In fact, HCG, when we look at placental levels, has a longer initial and terminal half-life than luteinizing hormone. It's been estimated that luteinizing hormone has an initial half-life of 1 hour with a terminal half-life of 10 hours, while HCG that derives from placental origins has an initial half-life of 5.5 hours and terminal 31 hours. As such, it is safe to say that HCG is the longest circulating molecule in human blood, and information on the half-life of pituitary HCG is limited. Now, I challenge anyone in the audience to please focus on this and to help us understand this about the pituitary HCG timeline. But it is important to know that there is adequate data to show how long HCG lasts in the body. So in my clinical practice, the way that I'm able to provide my patients with HCG-driven LH activity is by giving a drug called Menopur, which is a Ferring product. It is only Menopur that's able to provide this human-derived FSH and HCG for driven LH activity. The formulation that we have in the United States in Menopur is what we call a 1-to-1 ratio or a matched ratio, whereby there are 75 international units of FSH and 75 international units of HCG-driven LH activity. Now, the reason that we're talking about Menopur in clinical practice is because we want to be able to stimulate patients in an effective and efficient fashion. The dual action mechanism of Menopur can promote an endocrine profile that could potentially influence clinical outcomes. With respect to the theca cells, we know that LH binds to LH receptors, promoting conversion of cholesterol to androgens. With respect to granulosa cells, we know that thereby the FSH attaches to FSH receptors, stimulating granulosa cells and promoting conversion of androgens to estrogens. And of course, it is those androgens that move from the theca cells to the granulosa cells, ultimately, as there's folliculogenesis. Now, after diving into the science that we just talked about before, it's important to understand the clinical utility, because as clinicians in the audience, I would say that the most exciting thing is, what is this good for? How can we change patient outcomes? How can we provide better care to our patients and ultimately provide fewer cycles for our patients so that we can treat more patients? So what we're going to do is we're going to talk about 6 key studies here, where we are going to highlight the safety and the efficacy of Menopur in multiple clinical trials. The first trial that we're going to talk about is the EISG, which is the European Israeli Study Group on highly purified Menotropin versus recombinant follicle-stimulating hormone. This was a multinational, open-label, randomized, parallel group comparative phase 3 trial. Now, it is important to recognize that this is one of the first trials that has been done discussing Menopur or HPHMG, but also it's important to recognize that this was done via downregulation using a GnRH agonist. And I do know that many of us don't use GnRH agonists in our clinical practice as much as we now use antagonist-based protocols. But the results of this study are incredibly valid and important to highlight. So downregulation was performed using a long protocol, the long luteal lupron or the long agonist protocol. And the primary outcome of this study was looking at the oocytes per retrieval, ongoing pregnancy rates, or OPR, from 1 IVF ICSI cycle. Patients were downregulated. They were treated with 225 units of HPHMG or with recombinant FSH alone. They were then triggered. We transferred they transferred 1 to 3 embryos. And then ultimately, progesterone luteal support was done per clinic regimens. From this study, what we saw was that when Menopur was started on day 1 of stimulation, there was comparable efficacy to recombinant FSH when given as an initial starting dose of 225 units per day. Menopur was effective in both IVF and ICSI cycles, and the safety profile was similar between the two. So it's important from this study to recognize that there was no detriment by utilizing Menopur as your stimulatory agent. The next study that's frequently quoted is the MERIT study. And in the MERIT study, this was a randomized open-label, assessor-blind parallel group, multi-center, multinational phase 3 trial. Once again, the primary outcome measure here was ongoing pregnancy rate per started cycle in those that were randomized. Now, in these patients, also downregulation occurred using a GnRH agonist. Again, 225 units were treated, but this time now for 5 days, or using recombinant FSH. Then they were triggered with 250 micrograms of HCG. In the United States, we frequently call that drug Avidril. And then they were supported with vaginal progesterone gel for luteal support. Again, what happened in this trial was that you would adjust the dose accordingly to a maximum dose of 450 units after day 6. And then ultimately, when you had 3 follicles that were greater than 17 millimeters, that's when the trigger occurred, with 1 to 2 embryos being transferred. Following the 2006 MERIT study, 2 subsequent publications reported additional factors and outcomes with HPHMG versus recombinant FSH alpha from the MERIT study. And the reason I'm highlighting these 2 is that you're going to see that actually this helps you understand when to use Menopur and how to use Menopur. In the first study, that subsequent study was done, ongoing pregnancy rates with HPHMG were followed after 1 IVF cycle. And then ultimately, what we found in those next 2 was that the endocrine status, and we looked at the embryo quality of both of them as secondary output outcomes. What's interesting to recognize from the MERIT trial is that the serum HCG levels can take at least 5 days to achieve a steady state following administration of Menopur or HPHMG. The reason I'm highlighting this for you is that if we go back for a second, you'll take a look here. It was on day 6 that adjustments were made. So they were given 5 days of treatment, assessed, and then treatment was either kept the same or changed. So here you'll actually see in 3 different groups that ultimately it takes a number of days, 5 days, to achieve a steady state of the serum HCG level after giving HPHMG from the first day of stimulation. That is important when we're going to talk about the clinical cases at the end of my lecture. Day 6 HCG concentrations, in fact, were positively correlated with top quality embryos in this MERIT retrospective subgroup analysis. As in fact, what they found was that those who had a better day 6 HCG concentration ultimately had better outcomes. In fact, the reason they had better outcomes is quite obvious. It's usually related to top quality embryos. And we know that top quality embryos lead to higher ongoing pregnancy rates and live birth rates. And in those individuals in the pink columns, which are those that were treated with the Menopur or the HPHMG, there was statistical significantly difference in the transfer of top quality embryos versus the transfer of non-top quality embryos. So what did we take away from the MERIT trial? In patients undergoing IVF using a GnRH agonist protocol, Menopur demonstrated comparable efficacy, safety, and I would argue efficiency when given as an initial dose. There were some major differences in the endocrine profiles that were observed between those treated patients, which could influence clinical outcomes. But stimulation with Menopur produced significantly more top quality embryos per oocyte retrieved. Implantation, ongoing pregnancy, and live birth rates were also significantly higher with Menopur and top quality embryos compared to recombinant FSH. Now, one of my favorite trials is the MSART trial. And I always have a hard time remembering exactly what it stands for. So I've highlighted this on the left for you. This is the Menopur in GnRH antagonist cycles with a single embryo transfer. If you want to think what this means, this is how I treat patients every day. This is what Brian does, Dr. Levine does every single day, which is that I almost always use antagonist protocols, and I favor a single embryo transfer whenever possible. In the MSART study, which was published in 2012, this was a randomized, open-label, assessor-blind, parallel group, non-inferiority study. There was no contraceptive programming that was allowed, which means that there was no downregulation using birth control pills or oral contraceptives. And it was a compulsory single blastocyst transfer on day 5, with the primary outcome being ongoing pregnancy rates per cycle started. So in this trial, they were able to use the data and the insights that they gained in the previous trials, in the MERIT trials, understanding that you should not change the dose of your HPHMG or Menopur after 5 days. So ultimately, you administered 150 units of Menopur or recombinant FSH beta for 5 days. And then the doses were adjusted by 75 units on 4 days after the 4th day to be on to the 5th day. Ultimately, when there were 3 follicles greater than 17 millimeters, they were triggered again using Avidril or 250 micrograms of HCG. And then ICSI was done, and then ultimately 1 embryo was transferred, which was a blastocyst, and then pregnancies were assessed. And progesterone, luteal support was accomplished through progesterone supplementation. So what we saw here was that there was no statistical significantly difference between any of the groups, between HPHMG and beta recombinant FSH for those pregnancy rates per cycle started. But it's important to understand that one of the reasons they didn't see this difference is because they didn't actually power the study to do so. So what did we learn from MSART? We learned from MSART that Menopur demonstrated comparable efficacy to recombinant FSH when administered at a starting dose of 150 units. We also learned that the safety profiles were similar between the two. Treatment with Menopur was also associated with a lower rate of high ovarian response, more good quality blastocysts, lower progesterone estradiol ratios at the end of the stimulation, and improved pregnancy outcomes in potential high responders. Now, in point number 3, you might ask, why am I highlighting lower progesterone estradiol ratio at the end of stimulation? Well, as we all know, premature progesterone surging or rising during a cycle can have a negative effect on the programming of the endometrium of the uterus. And in a study or in a clinical setting where you're going to be ultimately transferring an embryo in a fresh embryo transfer, premature progesterone exposure to the endometrium will ultimately lead to worse outcomes. As such, I think one of the most important aspects of the MSART is point number 3. Keeping that progesterone low means you're keeping that endometrium ready for implantation. Now, again, in the MSART, it was important to know that the ovarian, as we said before in point number 1, the ovarian response was tempered. So actually a subsequent study was done, MSART HR, which is the high responders. And I'm not going to go too far into this because the next esteemed speaker will be highlighting this treatment protocol. But I just want to show that there is an advantage of retrieving or a disadvantage of retrieving more oocytes. So what we saw here in the MSART HR was that there was an advantage of retrieving more oocytes that diminished through time, through the course of embryo development. So if you look on the left in the pink, that's the HP-HMG group. And on the right in the black bar, that's the recombinant FSH group. And even from the offset at time of harvest or retrieval, there was a 7.1 average egg decrease in the number of eggs that were retrieved. But if you take a look at the end, at the number of excellent blastocysts on day 5, you can see that that change was really not noticed whatsoever. In fact, per ratio, per egg retrieved, you had better excellent day 5 blastocyst performance. Stimulation with Menopur resulted in 7 fewer oocytes per patient, but only 0.9 fewer excellent quality blasts. When given as an initial starting dose of 150 units, it had comparable efficacy to recombinant FSH in high responders who underwent ICSI. The rates of OHSS, or ovarian hyperstimulation syndrome, were significantly lower in predicted high responders treated with Menopur. And I think this is one of the most important points to highlight, because as physicians, we've all taken an oath to do no harm. And we know that treatment with gonadotropins must be done with care and compassion. We also found that patients treated with Menopur achieved similar live birth rates with fewer transfers and embryos. And ultimately, the early pregnancy loss rates were lower in predicted high responders treated with Menopur. So let's summarize this research because we want to talk about these clinical cases. So if you put the 4 trials together that we were talking about before, where the primary endpoint across all of these was an ongoing pregnancy rate, what we see here from this data is that Menopur, or HP-HMG, is an effective, efficient way to stimulate our patients. The live birth rates were consistently comparable between Menopur versus the recombinant FSH groups in multiple studies. In a meta-analysis, the data actually demonstrated that there was a significantly higher live birth rate with Menopurs in Menopur groups compared with recombinant FSH groups. The power of this meta-analysis is that when you take the data and you aggregate it together, you actually start to see here that there is a better live birth rate. Now, it's important to understand that many of these studies here were designed to show non-inferiority. So live birth rates are consistently numerically marked, but it's actually not the primary endpoint, and it only can be done when you aggregate these studies together in a meta-analysis form. To help put this together a little bit more, I looked to our friends at the Cochrane Review. And what we found in the 2011 Cochrane Review was that they tried to put together as many studies as possible. In fact, they found 42 of them, with 9,600 plus couples that were going through IVF. And what they tried to do at the Cochrane Review was to analyze all the available evidence comparing recombinant FSH with urinary gonadotropins using a common inclusion criteria and statistical methods. Of course, they looked at IVF ICSI cycles, and like we've continued to talk about this morning, they looked at live birth rate and OHSS as their endpoints. What they found was that there was no difference in the overall live birth rate or OHSS rates between the 2 groups. However, on the subgroup analysis, when different urinary gonadotropins were considered separately, there was a significantly fewer live birth rates after recombinant FSH than with HMG. This means that for a live birth rate of 25% using HMG, use of recombinant FSH instead would be expected to be in the rate of 19 and 25% respectively. We also know that we've compared Menopur to other drugs that are out there. Again, corfolotropin alpha is not available in the United States, but I do like this study because in this study here, they took a look at using corfolotropin alpha compared to HP-HMG against Menopur in the ovarian stimulation of patients at risk with premature ovarian failure. What we found ultimately was that Menopur from day 1 of ovarian stimulation resulted in a higher number of M2 oocytes, or mature eggs. And as we all know, mature eggs in the lab is your best chance of having an embryo on the other side and an ultimate outcome of a pregnancy. And what we see here ultimately is that the ongoing pregnancy and live birth rate was higher in the Menopur group. Menopur commenced on early follicular period, increases the live birth rate, of course, in the Poseidon groups of 3 and 4. And again, those are in your very low ovarian reserve patients. It's important to recognize that in these studies, these were mixed protocols, which meant that you were using recombinant FSH or alpha recombinant FSH with HMG. And the dose of the FSH was 225 to 300 units. And HMG was either used as Meganon or Menopur. And the HMG dose was much lower. It was only 75 to 150. But we do see here that there is a difference between the three. And then ultimately, early follicular HMG does provide you statistically significant better outcomes per cycle started, per oocyte retrieved, and per embryo transfer. So we go back to this story again. The dual action mechanism of Menopur can promote an endocrine profile that could potentially influence clinical outcomes. If we know that LH binds to LH receptors, promoting the conversion of cholesterol to androgens, and androgens become estrogens, and we know that that receptor is there early, it only makes sense to start your exposure to HPHMG early in the ovarian stimulation. In fact, starting LH earlier rather than later can have much better outcomes. We know that LH affects the human follicular development during most stages of folliculogenesis, and that the LH receptor influences the endocrine environment. LH is going to provide you a balanced drive of both granulosa and theca cells, ultimately supporting the best folliculogenesis, hopefully, ultimately, for producing the best IVF outcomes. Regardless of the protocol, there is evidence to suggest that patients should receive HCG activity from day 1 of their treatment cycle for 3 key points today. 1, we've demonstrated to you that it takes several days to achieve a steady state of hormone concentrations. 2, the higher the HCG level on day 6, the higher the live birth rate and ongoing pregnancy rate. And 3, 80% of the antral follicles that are 3 to 10 millimeters contain some element of the receptor on the granulosa cells, and so they should respond to the HCG. So don't not treat them. Make sure you're treating early. So now let's talk about some cases in the last few minutes before we go on to our next lecture. I've put together here 3 cases and how I would actually treat this patient. The first case is a 37-year-old G0P0 trying to conceive for 18 months. She has regular cycles and has an anti-Mullerian hormone of 1.25 with an antral follicle count of 10. If this patient were to move on to in vitro fertilization, I would say that this would be a classic patient or a standard patient that we would see in our clinical practice. And the protocol that I would choose for her would be with estrogen priming. And again, as we know from the other studies that we talked about before, many of them were done with non-priming. But I like to use estrogen priming in those patients who are a little bit older to allow for a more concerted, concentric, consistent growth of follicles with stimulation. But for this patient here, I would give her a matched dose, giving her a mixed protocol, using 225 units of recombinant FSH and 225 units of HPHMG. I would treat this as an antagonist cycle to afford me the ability to use a dual trigger. That's a trigger using HCG and an agonist trigger. Ultimately doing ICSI to try to maximize her opportunity for fertilization. Deploying PGT-A for genetic testing of these embryos, given that she's 37 years old. And then ultimately doing a single embryo transfer of a euploid embryo as a frozen embryo transfer. High responders. So a 32-year-old woman who comes to your office asking to cryopreserve eggs or oocytes for fertility preservation. You ask her when her last period was, and she reports that she's anovulatory. And when you test her serum hormone levels, you note that she has an anti-Mullerian hormone of 6.5 and an antral follicle count of 24. In this case, I would actually use a birth control priming for the patient. The birth control priming here is going to actually help us bring down her serum hormones to let them start at a baseline. But we would recognize very quickly and very early that as you're going to allow for profound suppression as a result of that birth control priming, you would need to use HPHMG as the only way to offer her LH activity throughout her cycle. In fact, I will argue that this is probably one of the most challenging cases that we treat as clinicians, and the recognition that using birth control as a priming agent ultimately leads to profound lowering of pituitary endogenous hormones underscores the importance and the utility of deploying HPA-HMG in the stimulation. So in patients like this, I routinely will give very low doses of only 50 units of recombinant FSH, with really the majority of the stimulation being driven by HPA-HMG using 150 units of Menopur. Again, this would be antagonist cycle, but as opposed to the last cycle, to help mitigate and to help remove the risks of ovarian hyperstimulation syndrome, I would use a Lupron-only trigger. The last case to discuss is probably the case that we see almost every single day. The patient who's 42 years old, who's been trying to conceive for a number of months, has irregular or shortening cycles. An initial assessment of this patient demonstrates that she is a poor ovarian reserve with an AMH of 0.24 and an antral follicle count of 4. In this patient, I would actually estrogen prime her again to help synchronize her follicles to allow for consistent concentric growth. I would then use clomiphene citrate as part of her stimulation protocol as an adjuvant to help improve both the sensitivity and response and to also capitalize upon her own endogenous pituitary-driven hormones. And I would use a single agent of only HPA-HMG in this patient of 300 units daily. You don't need to go past 300 units because you know that the receptors are only far and few between. Ultimately, I would give her an antagonist-based protocol, as we talked about before. And then again, the rationale behind the antagonist is to afford me the ability to use a dual trigger using HCG and an agonist to provide us hopefully with the best opportunity for mature oocytes. I would use ICSI for her to again maximize the fertilization potential. And given that she is 42 years old, you'd want to deploy PGTA to allow for the banking of embryos as much as possible, dependent upon ultimately her reproductive goals and her intent with her family building, and then a frozen embryo transfer. I'm going to stop here, and I want to thank you all for your time and attention. I hope I did not go too quickly, but I know that we will revisit a Q&A at the end, and I will give back my last 3 minutes to the next speaker, who I'm sure is much more interesting than I am. Thank you.
Thank you very much. Thank you very much, Dr. Brian Levine. That was a very exciting, very informative talk. Yes, I would like to remind the audience that you can send your questions through the Q&A chat box. We can see that there are some questions now, but I welcome more questions coming in before we end the session. And I think it's now for me to introduce the second speaker. It'll be Professor Michel DeVos. He's an associate professor in reproductive medicine and senior medical director at the Center of Reproductive Medicine in UZ Brussels-VUB. He studied medicine in Ghent, Belgium, and holds a PhD in medicine from the University of Leeds in the UK. And in 2011, he was recognized as a subspecialist in reproductive medicine and surgery by ASHRAE and the European Board of ONG. His current research activities are focused on reproductive endocrinology, PCOS, IVM, oocytes, and fertility preservation. He is the coordinator of POTO, which is the Freezing Ovarian Tissue and Oocytes Consortium, encompasses fertility research projects in VUB, University of ULB, and the University of Catholic University in UCL. And he has authored and co-authored over 70 scientific articles. Now, with that, I would like to welcome Professor DeVos, and please proceed to your talk. Thank you. We'll have a Q&A session after that, and please pour in your questions through the Q&A chat box. Thank you.
Thank you, Dr. Hatta. Good evening, everyone, dear colleagues. I would like to applaud Dr. Levine for giving an excellent overview of the activity and utility of HPA-HMG. I'm pretty sure you will recognize many of his messages in the lecture that I will bring you now. And this lecture will focus majorly on women who have an increased functional ovarian reserve. Many of these patients have the polycystic ovary syndrome, and they represent up to 15% of our patients. So they are definitely a non-neglectable part of our patient population. Here are some disclosures, none of which are extremely relevant to this lecture today. So in this presentation, I would like to discuss the available data regarding an individualized approach to ovarian stimulation in women with a predicted hyperresponse, more specifically in women with PCOS. And I will discuss the purpose of ovarian stimulation in these patients. And I would like to reflect on how we can achieve optimal targeted ovarian response. And by doing so, how to reach an optimal balance between safety and efficiency of an IVF cycle. Now, as clinicians, we have learned to focus on ovarian response categories, and we can distinguish poor response, normal response, and hyperresponse. But on the other hand, in the majority of cases, the response is actually in accordance with the functional ovarian reserve, which means that the majority of women that we call poor responders actually have an appropriate response to their low functional ovarian reserve. So these patients actually, if you stimulate their ovaries, the number of follicles that will develop will probably be appropriate for the functional ovarian reserve that they have. Only a minority of women who exhibit poor response have an increased or a normal functional ovarian reserve, and then something happened to result in poor response. And this is unexpected poor response in these patients. And we can definitely do something about that. We can, in the next stimulation cycle, we can adjust the stimulation protocol to avoid poor response in women who have a normal functional ovarian reserve. Now, in this talk, I will focus more on women who have a predicted hyperresponse, and in many cases, these women also exhibit hyperresponse after ovarian stimulation. And these are the women who suffer more side effects compared to women with a normal or low functional ovarian reserve. So how do we approach women who have a predicted hyperresponse? And there we have to respect the recommendations and the guidelines that have been developed by the professional societies. And I'm working in Europe, so my framework is basically derived from what the European Society for Human Reproduction and Embryology has developed. And this guideline of the ESHRE stipulates that if you have a patient who has a predicted ovarian hyperresponse based on her increased functional ovarian reserve, increased antral follicle count, increased AMH levels, in this case, you stimulate the ovaries in a GnRH antagonist protocol, and you use a starting dose of 150 units of gonadotropins per day. And if you then indeed observe ovarian hyperresponse, then you trigger the final steps of oocyte maturation using a GnRH agonist rather than HCG, and you cryopreserve the embryos rather than performing a fresh embryo transfer so as to avoid the occurrence of OHSS. So this is what we have learned from the recommendations of the professional societies. Now, we in Brussels have done some studies on hyperresponders, and we did a randomized controlled trial in women who had excessive response defined by more than 17 follicles of more than 10 millimeter on the day of trigger. So these women, if we observed this response, we randomized them into two groups. One group had a fresh embryo transfer, and the other group did not have a fresh embryo transfer, but all embryos of good quality were cryopreserved. And if we compared the outcomes in these patients, we saw that the cumulative live birth rate after 24 months was similar. More than 70% of women had a live birth. But if we looked at the side effects and complication rate, there we saw that there was a significant increase of moderate or severe OHSS in women who had a fresh embryo transfer in spite of an excessive response. So this has urged us to abandon the fresh embryo transfer protocol after doing this study. So if you look at the cumulative live birth rates in women with PCOS, then you have to conclude that the more oocytes these women have on the day of egg retrieval, the higher the cumulative live birth rate. So basically, these are patients who have an intrinsic optimal prognosis when they undergo IVF treatment. And this has also led us to conclude that severe OHSS is a problem from the past, and that we should more focus on cumulative outcomes after accumulation of embryos in a freeze-all protocol, rather than focusing on OHSS mitigation, because severe OHSS is a problem from the past if you cryopreserve the embryos after a GnRH agonist trigger. On the other hand, I think we have to remain vigilant, because severe OHSS is not the only adverse event in women with a predicted hyperresponse. Although severe OHSS is probably not possible after a GnRH agonist trigger and a freeze-only approach, up to 1/3 of women still exhibit mild or moderate OHSS. And this is characterized by abdominal bloating, abdominal pain, and hormonal side effects. These women may also, but rather rarely, have ovarian torsion. And they will definitely tell you that they suffered from the ovarian stimulation. When you look at the ovaries by ultrasound scan after a GnRH agonist trigger, you can observe in many of these patients ovaries with a very large diameter. Here I can show you a picture of ovaries that measure more than 10 centimeter by more than 7 centimeter diameter. So these ovaries are definitely enlarged, and this results in side effects and abdominal pain. And according to a study in the Netherlands, where they asked hyperresponders what they actually found very valuable in ovarian stimulation, then 50% of the hyperresponders said that they would accept a lower chance of pregnancy for a reduction of the OHSS rate. So basically, we have to look for a good balance between success rates and complication rates or side effects. And this is not the only issue in women with PCOS. We also know that AMH and body mass index modulate the ovarian response to stimulation. Now, I would like to give an example. This is a patient with ovaries that have an increased antral follicle count. So we are looking at polycystic ovaries, elevated AMH levels. This is a woman who does not have increased testosterone production from the ovaries. She has an irregular cycle, but she's not amenorrheic. She has a normal body mass index. Now, if you stimulate the ovaries of such a woman, she will exhibit a more linear dose-dependent ovarian response. So what you get is actually what you do when you stimulate the ovaries. There is no hidden surprise in ovarian stimulation in these patients, and they will have a very favorable outcome. On the other hand, some patients with PCOS have increased androgen production, extremely high levels of AMH. Amenorrheic patients increased body mass index. And these patients will have a more unpredictable ovarian response pattern. Very difficult sometimes to stimulate these predicted hyperresponders in a good way. They will often exhibit low response because the ovarian stimulation will not reach the threshold that you need to stimulate several follicles at the same time. So they may give you sometimes difficulties to have a good result. And this is what it's all about. When we look at the functionality of the anti-Mullerian hormone at the level of the FSH receptor, there we see, and this is based on studies from France, that the higher the anti-Mullerian hormone level, the more difficult it will be for the FSH to stimulate its receptor and to achieve follicle growth. So high AMH means that it will be more difficult to have a controlled ovarian stimulation. Now, I would like to ask you to reflect on this specific case. Consider a patient who has polycystic ovary syndrome, who has an increased body mass index of 28 kilograms per square meter, a body weight of 81 kilograms, and an anti-Mullerian hormone level of 5.8 nanograms per ml. Now, I would like you to stimulate this patient in a way that you think is appropriate. Would you recommend starting ovarian stimulation with 100 units of gonadotropins per day, 150, 200, or 225? The poll is now open, and I would like you to make a choice. We'll give you some time to reflect. Now, I would like to ask the organizers whether I can see the results of the poll.
Yes, I think we can. Can you?
Okay, because I cannot see the results of the poll.
We are putting up the poll, the results of the poll now.
Okay. So if you could put up the answers, that would be great. Okay. Can anyone display the answers of the poll? Okay, maybe we can keep the answers for later on during the Q&A session, and I will now continue my talk. I would like to also refer to an example, a patient with PCOS who is 33 years of age. She already has a child. She has secondary infertility since 2 years. She has oligomenorrhea, no clinical signs of increased androgen production. Her husband has a normal sperm count. She has had 6 unsuccessful cycles of ovulation induction with letrozole and a normal tubal function test and a body mass index of 27. And at the same time, I can see, yes, I can see the results. Perfect.
Delayed, yeah.
Thank you so much. So here, the majority of respondents, 62% of respondents would indeed stimulate the ovaries of this specific patient with increased body mass index with a starting dose of 150 units per day. But no less than 31% would prefer an increased dose. And I think they may have chosen to do so because of the increased body weight of the patient. So indeed, in patients with PCOS, sometimes it may be interesting to stimulate with a slightly higher starting dose of gonadotropins if the patient has an increased body weight and an increased body mass index, to make sure that you can reach the thresholds of FSH stimulation and to avoid oligofollicular response. But let's talk about this in a few minutes. Now, this patient, the example that I'm providing here is a patient who has indeed an increased anti-Mullerian hormone. She has normal levels of testosterone. So we can conclude that this patient has a PCOS phenotype D. And what does this mean? This means that this patient has the specific phenotype of PCOS without hyperandrogenism. And according to some PCOS experts, this phenotype does not actually represent PCOS. It's a reproductive phenotype without the metabolic risks of hyperandrogenic PCOS. So in this patient, we started ovarian stimulation with 150 units per day of HPHMG. And in Brussels, we usually start antagonists on the 6th day of ovarian stimulation. And we did so in this patient, but she had a relatively modest increase of estradiol, 166 picograms per ml. And as you can see here, the dose was not increased during ovarian stimulation. And I'm sure that you may have questions about this. I think we can definitely say that increasing the dose after 1 week would have probably be interesting in this patient, but we didn't do so. So she was actually stimulated at the same dose for more than 2 weeks. And in the end, only 2 large follicles emerged. So this was actually a failed cycle. Cycle was canceled. And we started stimulation again with an increased dose of gonadotropins. We used 225 units per day from the start of stimulation, HPHMG, and this was much better. And she had more than 19 follicles of more than 11 millimeters. And we obtained 24 oocytes, and she produced 7 blastocysts after in vitro fertilization, and she got pregnant in a artificial cycle, as you can see here. So basically, this was a poor start of IVF in this specific patient, but just to give you an example of how important it is to adjust the starting dose in accordance to the patient's body weight. Now let's move on to a classical misunderstanding in IVF practice. We have learned from retrospective data published by Greek clinicians, Nikos Polizos, and also Drakopoulos has done the same exercise, where they looked at cumulative live birth rates in function of the number of oocytes obtained at egg retrieval. And they observed that the more oocytes a patient had, the higher the cumulative live birth rate. Now, the problem is that these are retrospective data, which may be biased to some extent. It is often ignored that an observed relationship between a high oocyte yield and favorable IVF outcomes actually represents just the good prognosis patients. So patients who have the potential to produce many oocytes at egg retrieval are patients with a very favorable prognosis. They have a good functional ovarian reserve, and no matter how you stimulate these patients, they will also have a good prognosis. We should not interpret these data as when patients have a suboptimal ovarian response, and when we try to increase the dose of gonadotropins in order to have more oocytes, we should not believe that in all cases these patients will have a higher live birth rate. So by trying to convert a suboptimal or a normal responder into a high responder, there is no evidence from prospective studies that this will definitely result in increased live birth rates. So very important to distinguish between observational data, which are presented here, and the prospective data that are not existing. There is no prospective study that has given evidence about an increased cumulative live birth rate when you increase the dose of gonadotropins in a specific response category. And this brings me to a message that was also provided by Dr. Levine. The goal of ovarian stimulation is actually to selectively recruit follicles of good quality. And selection of follicles also means that some follicles will be deselected. Some follicles will become apoptotic when you perform ovarian stimulation. And this is actually the goal of ovarian stimulation. You don't need all follicles to grow and to give you an oocyte, because some of these follicles will have an oocyte that has a very poor potential. And the importance of ovarian stimulation is to make sure that you select the best follicles. And this was in a very elegant way also provided by the study of Arce 10 years ago now. And this was a study with Recoval, where they found that increasing the dose of Recoval did actually result in more oocytes, but did not result in more good quality blastocysts. So it's very important to understand that if you stimulate harder, that you do not necessarily obtain more good quality blastocysts. So hyperresponse is actually a double-edged sword. You can definitely avoid severe OHSS these days when you observe hyperresponse by freezing all the good quality embryos, but it's not without risk. And there is also the problem of a very high number of redundant embryos that may probably not be used by the patient. So it is very important to perform ovarian stimulation in an intelligent fashion. Now, in the Netherlands, which is a neighboring country of Belgium, ovarian stimulation in hyperresponders has been approached in a different way. They performed the Optimist trial a couple of years ago, where they randomized patients, hyperresponders, into a low dose ovarian stimulation and a normal dose of 150 units. And in the group with the low dose of 100 units of recombinant FSH per day, they actually observed that the ongoing pregnancy rate after the first IVF cycle was not significantly worse compared to the standard dose of 150 units, but they had many more cycle cancellations and poor ovarian response in the low dose category. So this is probably not a good idea. If you stimulate a hyperresponder in a very cautious way, then you will probably have more cycle cancellations due to poor response. So it's more important to try to exploit the ovarian follicular reserve of a predicted hyperresponder. Now, let's look again at the type of gonadotropin in predicted hyperresponders. And here again, the MSART HR study that was already mentioned by the previous speaker, where 620 hyperresponders were randomized into receiving HPHMG and or recombinant FSH. And in spite of a higher oocyte yields in patients who received recombinant FSH, the increased number of top quality blastocysts was very marginal. So this means that many of these incremental oocytes did not result in top quality blastocysts. And the cumulative live birth rate after 6 months was similar in these two groups. And more importantly, the divergent ovarian response was actually very remarkable. So what I mean by divergent ovarian response is depicted here. So in women who received recombinant FSH, the response was actually much faster. So more follicles of intermediate size were seen after 9 to 10 days of ovarian stimulation. Whereas in women who received HPHMG, ovarian stimulation was more balanced, was slower. So it actually took more time for the ovaries to react. And the divergent pattern of ovarian response has also been highlighted by the previous speaker already, in that follicles, antral follicles, most commonly express FSH receptors and very rarely express LH receptors. But the proportion of follicles that express LH receptors will grow with increasing size of the follicles. So by the end of ovarian stimulation, the majority of gonadotropin receptors will be LH receptors and not FSH receptors. And this explains why a product that contains pituitary HCG and that will bind on the LH receptor will give a different pattern of ovarian stimulation compared to a stimulation that contains only FSH or recombinant FSH, where there will be a brisk development of follicles after the start, but then it will slow down a bit more. And perhaps this divergent pattern of ovarian response between HPHMG and recombinant FSH may explain why in the MSART HR study, the observed early pregnancy loss rate after HPHMG was significantly lower compared to early pregnancy loss in women who had recombinant FSH. And this is still puzzling, and we do not really know where this result comes from, but it definitely has to be confirmed in prospective studies. The MSART HR study was not powered to demonstrate a significant difference in early pregnancy loss between the two groups. So this merits further investigation. Now, the strengths of the MSART HR study were that it was a multi-center randomized controlled trial. It was the first trial to use serum AMH as a marker to prospectively identify potential hyper-responders. Now, the study was unfortunately only powered for the primary endpoint, and this was ongoing pregnancy after fresh embryo transfer. And if you look at hyper-responders, it may make more sense to look at cumulative live birth rate as a primary outcome variable. So this needs to be studied in further prospective trials. Now again, reflecting on the divergent ovarian response if you perform ovarian stimulation with a product that contains HCG is depicted here. And this is, I agree, a repetition of what the previous speaker has already mentioned, but it's important to repeat important messages now and again. So although HCG and LH bind on the same receptor, there is increasing evidence that HCG binding will generate a greater intracellular accumulation of cyclic AMP compared to LH binding. And as a result, there will be a pro-apoptotic effect if HCG binds to the receptor. Whereas if LH binds to this same receptor, there will be an anti-apoptotic effect. So HCG may result in fewer oocytes, but the reduction of oocytes is actually a good thing. It means follicle selection. So when we look at the MSART HR data in hyperresponders, we can say that compared to recombinant FSH stimulation, hyperresponders treated with a gonadotropin that provides pituitary HCG will benefit from less excessive ovarian response, a similar live birth rate, and less early pregnancy loss. Nevertheless, PCOS is a heterogeneous reproductive metabolic condition. And I don't need to repeat the classification of PCOS because this is probably all known to you. But we just looked at a patient who had PCOS phenotype D. And as you can see here, phenotype D means that the patient has a polycystic ovary-like morphology, and she has anovulatory dysfunction, but she has normal androgen production. Whereas the other three phenotypes all share the increased androgen production. And this is a more prognostically worse phenotypes because these phenotypes are related to adverse obstetric events such as hypertensive disorders of pregnancy and preeclampsia. On the other hand, if you look at increasing age in women with PCOS, has a very limited effect on outcomes after IVF because these women will be able to exploit their good functional ovarian reserve to compensate the age-related loss of fertility. Now, we in Brussels have done a study, a retrospective study on different phenotypes of PCOS when these patients underwent ART. And we found that the phenotype actually does not result in different clinical outcomes. There was no significant difference in cumulative live birth rate across the different phenotypes of PCOS, which means that a patient with PCOS phenotype D, which has normal androgen production, had a cumulative live birth rate of almost 80%, but this was not significantly higher than a patient with the reproductive, with the metabolic phenotype A, with increased androgen production. So this is actually a reassuring result because it means that if you treat a patient with PCOS, there is probably not an impact from increased androgen levels on the outcome of ART if, and this is of course very conditional, if you stimulate the ovaries correctly so as to obtain hyper response. Obviously, a patient with PCOS type A and increased body weight has a risk of exhibiting low response if you stimulate the ovaries with a dose that is not high enough for the FSH threshold. Now, in our patient cohorts, we found that only the number of oocytes retrieved and the embryo stage were predictors of outcome and not the phenotype. Now, we come to the last part of this lecture, and I would like to share with you a video of an egg retrieval in a patient with PCOS phenotype A, hyperandrogenic phenotype, very high number of antral follicles, where ovarian stimulation was attempted but did not result in follicle growth. And this is probably related to the very high level of AMH in this patient. And so we had to perform antral follicle aspiration from antral follicles in a cycle with very minimal ovarian stimulation. So in this cycle, we only give the patient 3 days of HPHMG. And after 3 days of HPHMG, the ovary just looks like this, small follicles, antral follicle size of around 5-6 millimeters. And we performed in vitro maturation of the oocyte of this patient. Now, in vitro maturation may be an option for patients with severe PCOS. According to the American Society for Reproductive Medicine, IVM is no longer considered experimental, and it can give reasonable outcomes in patients with severe PCOS if this is managed by centers which have an expertise in IVM. So when we perform IVM, we give just a few days of HPHMG to start follicle growth, and then we perform egg retrieval in follicles of less than 10 millimeter diameter, and we incubate the cumulus oocyte complexes for 30 hours in registered IVM media, and then we perform ICSI and embryo vitrification. And by doing so, we actually obtain very reasonable success rates. Just an example here, patient of 31 years of age, amenorrheic since she stopped taking the pill, desire for pregnancy for 2 years, increased body mass index of 30. She has had cycles of ovulation induction, and the patient has a very high level of anti-Mullerian hormone, 44 nanograms per ml, increased male hormone production. And in this patient, we were able to aspirate no less than 111 oocytes, of which 60 became mature after in vitro maturation. And the patient had several blastocysts cryopreserved and also some cleavage stage embryos. And she got pregnant after a frozen embryo transfer in an HRT cycle. Now, according to a recent study that we published in Human Reproduction, patients with very high levels of anti-Mullerian hormone, and we would say that very high levels would start at around 10 nanograms per ml. In these patients, the difference in cumulative ongoing pregnancy rate after one cycle is less than 10%. If you look at the yellow line, which represents the outcomes after IVM, and you compare this with the gray line, which is cumulative ongoing pregnancy rates after conventional ovarian stimulation, then you see that the higher the level of AMH in a patient, the less different the cumulative outcomes between conventional stimulation, the gray line, and IVM, the yellow line. And this is a retrospective analysis of patients with PCOS, more than 1,700 patients who had ART in our center. So this brings me to the second and last question for you. If you consider a patient with PCOS who has a body mass index of 28 and a body weight of 81 kilograms and a very high anti-Mullerian hormone level of 15 nanograms per ml, how would you approach ovarian stimulation in this patient? Would you stimulate her with a low dose of gonadotropins, a normal dose, an increased dose? Would you consider folitropin delta, Recoval, or would you consider IVM? And the poll is now open. Okay, and so we can see here that, interestingly, half of the IVF practitioners would consider in vitro maturation of oocytes in this patient. And the second preferred choice was an increased dose of gonadotropins, which I believe is a good choice because it will, an increased dose of gonadotropins will probably reach a threshold of FSH that is appropriate to obtain follicle growth. So I would like to thank you for these answers. Okay, so in conclusion, I think that we can consider 3 different approaches to ART in patients with PCOS. I would say that the less popular approach would be cautious stimulation. And cautious stimulation means that you are afraid to have too many side effects in the patient, and that you would prefer to have a fresh embryo transfer. So you would like to avoid hyper response. So there is a significant risk of poor response if you stimulate a hyper responder with the low dose gonadotropins. There is a relatively low risk of severe OHSS, and the patient will probably have a fresh embryo transfer. Then there is the standard dose stimulation, which in patients with PCOS will reasonably result in hyperresponse. You will have many usable embryos. The patients will have a very high cumulative live birth rate per cycle, and pregnancy will most commonly occur after frozen embryo transfer, which may result in increased obstetrical risks, at least if frozen embryo transfer is performed in an artificial cycle. If you perform a frozen blastocyst transfer in a modified cycle, I would say a cycle with ovulation induction, where you give the patient letrozole or clomiphene to stimulate the ovaries and to obtain a dominant follicle, well, in this case, the risk of preeclampsia will be relatively low compared to an artificial cycle. And then the third option, as I just mentioned, is in vitro maturation of oocytes. I would say this should be, at present, should be exclusively for patients with severe PCOS, because in all other patients with PCOS, I think the standard dose stimulation will definitely give you a good balance between success rates and safety. I would like to thank you for your attention.
Thank you very much, Professor Michel, for the excellent talk. We now open the floor for questions and answers. I would like to remind the participants that after the talk, we will have a short survey. Please answer the survey before once the webinar ends. I would also like to welcome our colleagues from Thailand. I see quite a number of participants from Thailand, besides Singapore and Malaysia. Welcome. Yes, I'll start with the first question. This is directed to Dr. Brian. Thank you for the excellent lecture. In case of abnormal FSH-LH ratio, LH is too low or less than 1.5 MUIU in unit per mil, how can I manage to start the COH? So in case of
So I think
abnormal FSH.
So it sounds like they're talking about someone who could be a hypothalamic patient where their
Yes.
levels are incredibly low. So hypothalamic patients are some of the most challenging patients out there. And I think they're a wonderful example of a patient where HPHMG actually makes all the difference in the world. The reason is that frequently you can see a hypothalamic patient who might be a high responder. And as such, if you give them recombinant FSH alone, what you might find is that that patient ultimately will just get a cohort of oocytes that'll be stimulated rather quickly, but you will not get consistent concentric recruitment of follicles along the way. In fact, one of the greatest mistakes that I've seen people make in these patients who are high responders but anovulatory due to hypothalamic reasons, it could be extreme weight gain or weight loss, it could be someone who's extremely stressed, it could be hypothalamic amenorrhea from a whole host of different reasons. But in those patients, it's important to recognize that they are at great risk of ovarian hyperstimulation syndrome if they have an elevated AMH or anti-Mullerian hormone. As such, these patients, I strongly advocate for monophasic, monoagent, solely just HPHMG to be used. And again, make sure that we do it for 2 days at first to see what the levels are, but don't change the dose ultimately, if possible, until day 5 or 6. Understanding from the clinical trials and clinical practice that you need to have at least 6 days of steady state to be able to see an impact on ultimate follicular genesis and outcomes using HPHMG for the HCG levels to hit their steady state.
What would be your dose to start off with? Because since they are hypo.
So if this is a patient who's hypothalamic amenorrheic with an elevated AMH, I would start her comfortably using 150 units of HMG, which is 2 vials in the United States, or sometimes we call it 2 amps, which is one of the ways you'll see the papers written. And if she's a low responder, I'd consider maybe going up to even 3 vials or 225 international units of HPHMG. If the FSH or if the AMH is really, really high, so again, we use nanograms per milliliter as our form here for AMH. So if she had an AMH, I would say greater than 10, I might drop it down to only 75 units of HPHMG. And what is important for people to understand is that with administering Menopur or HPHMG, even though we're talking about intervals of 75, it is possible to do other intervals. In fact, it is possible to do 1.5 vials if you want to give a patient 112.5, for example. So you can customize the dose. And it's very simple, is that combining 2 vials and then taking out only a subfraction for that 112.5.
Okay. Thank you. I hope that answered your questions. I go to the next question. This is quite interesting. What is your estrogen priming protocol, Dr. Brian?
There's hot debate about the utility of estrogen priming protocols. And the reason I'm laughing is that when I give lectures all around the world, this is the #1 question I get is about estrogen priming, no matter what the topic of the lecture is. It could be about ICSI or euploid embryos or HPHMG. Everyone always wants to ask about estrogen priming protocols. And I think it's a stylistic thing. So my protocol is that I like to give the patient, whenever possible, as little medications as possible. May that be gonadotropins, may that be priming protocols, may that be stimulatory medications. As such, I frequently will have the patient in the preceding cycle monitor for ovulation, either spontaneously on their own, using an ovulation predictor kit, or using serum blood work. Ultimately, once ovulation surge is confirmed, the LH peak, we'll then have them do a blood test to confirm that they have progesterone 5 days later. And then once we believe that they're past their peak progesterone level, so typically on day 21 or 22 of their endogenous natural cycle, I will start them on an estradiol patch. Alternatively, you could give them synthetic oral estrogen of 2 milligrams once or twice a day. Of course, that's going to be equivalent to using a 0.1 patch that you would give for a patient as well. But in general, I tend to give it for 5 to 6 days preceding the onset of menses. And then ultimately, I have the patient stay on the patch once they get onset of bleeding. Part of the reason for using estrogen priming is that it's less suppressive than using the birth control pill. And as you saw in both my lecture and the following lecture, LH is actually really important in the endogenous folliculogenesis. And so basically blunting the LH that's either endogenous or exogenous during a cycle could have disastrous outcomes ultimately in both yield and quality. And so for me, I really try to use as little medications as possible that are going to lead to a lowering of endogenous LH throughout a cycle.
Okay, thank you very much. That's very interesting. So I suppose the birth control priming is almost the same as well.
Correct. So there's multiple forms of priming. You can do progesterone priming, where people sometimes will give progesterone supplementation to help synchronize a cycle. Some people will use birth control pills for either what we call the short course or the long course of a cycle. So there's a multiple of modalities that can be used throughout the way. But for me, I really do prefer estrogen priming whenever possible.
Okay, all right. I'll go to the next question, but I think this is already explained in your talk. It's from Su Ling. Why do you use a mixed protocol? Why do you use a mixed protocol with common FSH? Yeah.
So in general, I like to split dose as well, which is something I didn't touch on in this lecture, which is I like to give my HPHMG in the morning, and I like to give my recombinant FSH in the evening. And so when I split the doses and use the mixed protocol, part of it is for the twice daily injections that I like to give the patient. Again, the reason I give the HPA-HMG in the morning is because endogenous LH levels also surge closer to the morning time, and it makes more physiological sense to be giving the FSH in the evenings for the patient, instead of giving just one bolus of all the medications at the night, as many people typically are prescribed. With that said, some of the best results have been demonstrated that when you do have a mixed protocol, especially in those medium to low responders, you do get better concerted growth, and you can sometimes avoid that dominant follicle that's there. So I use it as an additional stimulation.
That's interesting.
And it's just stylistic. It is stylistic, of course.
And when do you, out of curiosity, when do you start the antagonist? Or when does the patient inject the antagonist, in the morning or in the evening?
So I like to use antagonists in the morning because ultimately, if you trigger the patient, you then have the shortest interval between last antagonist administration and ultimate oocyte pickup. So trying to prevent the unfortunate situation of premature rupture or premature ovulation before oocyte retrieval. So I like to use my antagonist in the morning. Now, many of the studies that I referenced before start the antagonist almost empirically on day 6 of stimulation. However, in my clinical practice, because sometimes I am using estrogen priming, I do find that people will stimulate for longer than 10 to 12 days. As a result, I do try to keep the cost of the cycles down because medications are very expensive in the United States. And also I try to limit the amount of antagonist exposure because we really don't have data on what happens after 6 days of antagonist administration. And I think that'd be a wonderful study for someone to do about premature initiation of GnRH antagonists, but we don't have the data yet. As such, I tend to use ultrasonography as my key tool for understanding where to go. If the patient has a follicle that's of 13 millimeters or greater, and again, we measure all of our follicles in 2-dimensional form, so the X and the Y axis, right, 2 different measuring points. If they have a 13 millimeter or greater, that is, to me, the point to initiate the GnRH antagonist during the cycle. I will also share that if you looked at my low responder patient, the POR patient, the Poseidon, stage 3, 4 patient, in those patients, I also use continuous clomiphene citrate administration throughout the cycle. Using clomiphene citrate administration throughout the cycle, one of the benefits is it does up the endogenous LH release that you'll have for the patient, but B, it also blunts the ability to have a surge. As a result, I can limit the amount of antagonists, and when someone's on continuous clomiphene citrate, I will start their antagonist at 14 millimeters of ultrasonography findings.
So you start based on ultrasound findings. Some protocols start on fixed date of 6 days of stimulation. Do you find premature ovulation?
Many of the studies. No. So if you're careful and you monitor the patients, it's almost nearly physiologically impossible to ovulate at 13, 14 millimeters. The problem that we find with premature ovulation or the breakthrough is in the patient who has a high resting LH and it wasn't recognized throughout the cycle. So actually you start seeing their LH creep up and you start to see, for example, a luteinizing hormone of 12 or 13 or 14, and then you did not give the patient an additional antagonist to compete with that. Because sometimes a patient can break through the antagonist, right? This is why throughout my career, I've modified my monitoring protocols, and I actually measure 3 analytes whenever monitoring a patient. So I look at their estradiol levels, their luteinizing hormone levels, and progesterone levels. And as a result of looking at luteinizing hormone, progesterone, and estradiol levels, we recognize that doing that can give you the best monitoring of the patient possible.
Interesting. Again, a question from Suling. Would you use Recovel or Menopur for your PCOS patient? I think this question goes to Brian. Then after that, I will ask Prof. Michel what's his opinion on that.
I'm happy to answer questions if you want to email me as well, because I think we'll be good friends because I love talking about stimulation. I would love to use Recovel. I would absolutely love to use Recovel for these patients. We just don't have it in the United States. Our neighbors to the north in Canada love to talk about their Recovel experience. Our colleagues in Belgium and the rest of Europe love to talk about their Recovel experience. My colleagues in Asia talk about their Recovel experience. And I feel very left out because I actually cannot get access to this most wonderful medication because the medications in the United States are quite limited. With that said, Menopur or HPHMG is the backbone of my stimulation protocol for my high responders or PCOS patients. And I think as both Michel and I both demonstrated together, is that HPHMG will allow you to mitigate that risk of ovarian hyperstimulation syndrome. And I cannot underscore enough that we have an obligation and a duty to our patients to do no harm wherever possible. And the one thing that we can do with our patients that can injure them during stimulation is not to recognize the risks, the signs, and the potential mitigating factors for hyperstimulation syndrome. So I completely support, utilize every single day HPHMG, especially my high responders.
I would like
Prof.
to follow
Michel.
up.
Yes.
Yeah, I would
Yes.
like to follow up on what Dr. Levine has just said. I think Recovel is just another very interesting addition to our portfolio. If you have Recovel available, it means that you are able to combine patient characteristics such as body weight and AMH into a designed algorithm where when you adhere to the algorithm, you know that there is an increased chance that you will obtain between 8 and 14 oocytes after ovarian stimulation. If you believe that this is really important for the patient because it will allow her to have a fresh embryo transfer, then I think Recovel is going to be your friend. If you do not have Recovel, then I think that with Menopur, you will be able to stimulate almost all patients that you can think of without the need for Recovel. Because if you observe an increased response after Menopur, then it's easy to just trigger with an agonist and cryopreserve the embryos. I cannot really think of many reasons why you would try to focus on fresh embryo transfer in a hyper-responder. I think there are very limited indications for not wanting a freeze-only approach. I think the freeze-only approach is a very elegant way of dealing with hyper-response. And I think the obligation to have a fresh embryo transfer is more and more getting abandoned.
Having said that, Prof. Michel, in your experience using Recovel, do you have to add Menopur or just Recovel when you do stimulation?
This is a very interesting question. So in Belgium and in most of Europe, we usually perform ovarian stimulation with just a single agent. So the mixed protocols are very uncommon in Europe. On the other hand, if we look at the Canadian results with the combination of Recovel and Menopur, I can't think of the acronym of that study. The study was published by François Bissonnette in Fertility and Sterility 3 years ago. The MARCS trial, sorry, yeah, the MARCS trial, combination of Recovel and Menopur, and this gave excellent results in all sorts of patients, low responders and hyper responders, with more oocytes obtained and higher pregnancy rates. So the combination of Menopur and Recovel is certainly a combination to consider.
And to finish off the question from Suling, do you use Menopur for patients with PCOS? I'm sure you do.
Well, we know the MSART HR data. So we know that Menopur is a very good product for patients with PCOS. I think it's a misunderstanding that patients with PCOS who have high endogenous LH levels should not get Menopur. That's not true. Menopur gives you HCG to bind to the LH receptor, and this will result in apoptosis of less suitable follicles. And I think the evidence is there. Okay,
back to Brian again. The first question I think have already been answered. How do you carry out the estrogen OCP priming prior to stimulation? But I'll go to the second question. What are the doses of your dual trigger?
So we tend to give 4 milligrams of Lupron or 80 units twice. And we give them 12 hours apart. And so we will give an HCG trigger, and then 1 hour later, we will give the Lupron trigger, which is either 4 milligrams or 80 units, depending on your conversion. And then 12 hours again in the next morning, give another 80 units or 4 milligrams of Lupron.
That's interesting. I do practice dual trigger sometimes, and in Malaysia we have triptorelin, and usually we give 0.2 milligrams followed by Ovidrel, almost at the same time for dual trigger. Then but we find that we have more mature eggs with the kind of protocol.
I openly support the dual
again,
trigger, and one of the things I'll just highlight is there's a wonderful paper that I love to quote, done by Dr. Laura Meyer in Fertility and Sterility, 2014 or 13, somewhere around there, where they talk about the candidates for dual trigger. And so it's important that if you're going to deploy this, this tool, looking at the patient's endogenous LH profile throughout their cycle and during their cycle will let you know who can be a Lupron-only trigger or an agonist-only trigger versus a dual trigger. And so it's very important to understand that dual trigger will probably give you the best chances for maturity, but of course, giving HCG gives you the risk of having OHSS. So if you're going to do an agonist or a Lupron-only trigger, just know that you're picking the right patients for that trigger. Because the worst thing you ever want to do is take a patient to the operating room and have no eggs retrieved.
Okay, next question will be to Prof. Michel. In your opinion, what treatment will you give to patient who is lean PCOS but have a high AMH of around 90? I think it's picomole.
Picomole, yes.
Yeah, high FSH and lean FSH, yeah.
Well, if this patient has a very it's a lean PCOS, so it's a patient with a low BMI, so she's going to be a hyper responder whatsoever. So probably I think it's quite straightforward. If you stimulate this patient with 150 units per day of HPHMG, she will probably not exhibit a low response. She will just have an excellent response, and you will trigger with an agonist, and you will cryopreserve the embryos. I don't think this is a difficult patient to manage unless she does not have PCOS, and she may have amenorrhea as a result of hypothalamic dysfunction, and then you may have more problems, as Dr. Levine has just said, because if you then have 30-something follicles at the end of stimulation, and you cannot trigger ovulation with HCG, then you may have a problem. So in these patients who have hypothalamic dysfunction and high AMH, it may be tricky. But lean PCOS, if it's true PCOS, high AMH, I don't see a problem in stimulation in this patient.
You will start off with 150.
Yes, definitely.
But if the patient has a higher BMI, you would go 20 to 25.
Yes, that's what we would do.
And probably a step-down regime as you monitor.
Not necessarily, but you may do a step-down regime after 1 week or 8 days or so. But what we often do is just keep the same dose, and if you see that the estradiol levels are extremely high, then we add letrozole to reduce the estradiol levels. This is also a strategy that is often used in some clinics in the US. But reducing the dose of gonadotropins is something that we very rarely do, because there is a risk of, well, first of all, it takes time for a new steady state level to appear after adjusting the dose. So it takes several days of time before you reach a new steady state. So it's probably not a very popular thing to do to reduce the dose.
Just out of curiosity, in your experience, how long you have to stimulate a particular patient with PCOS, or how many days of injection, in your experience?
Well, in our experience, if you stimulate the ovaries in a PCOS patient with a dose that is not high enough for her, then yeah, you may need to stimulate for up to 3 weeks. But this is, of course, a very undesired type of stimulation. I would say that this is not what you want. Then that's why in women with increased BMI, you prefer to have a higher dose, a higher starting dose, so as to reduce the length of stimulation.
Okay, very good. Another question for Prof. The PCOS patient who had IVM, what was the gonadotropin dose that lead to cycle cancellation? If
Okay.
no IVM available, any role of ovarian drilling?
So exactly. So one of my colleagues had administered 150 units per day in that patient because she was afraid of having exaggerated ovarian response. So she used 150 units per day, but that didn't do anything to that patient because the follicles would not react to only 150 units per day. On the other hand, this was a patient with a very high AMH level. Ovulation stimulating with increased doses would have been an option, but then there is a very high risk of side effects, not severe OHSS, but definitely moderate OHSS. I think ovarian drilling has the potential to reduce the antral follicle count and AMH level at short term, where after, I would say, 3 months after ovarian drilling, you would probably have more favorable ovarian response compared to before the ovarian drilling. But this is not what we do because we have IVM available. But I think if you do not have a IVM available, then ovarian drilling is definitely a possibility to mitigate the extreme PCOS ovaries in your patients.
Okay. Another question to Prof. In Malaysia, starting dose of 150 in a normal responder will most certainly lead to a cycle cancellation due to a poor response. Do you have an explanation for this?
Well, I am not an expert of FSH receptor polymorphisms, but I'm pretty sure that depending on where you are, some patients, depending on their ethnical background, may have FSH receptor variants, which will probably result in a more blunted response to a certain gonadotropin dose. That's the only explanation I can think of, because if you start with 150 units per day in a patient with a normal BMI and she's a normal responder, then I don't think that you would have a high risk of cycle cancellation.
Yes, we do find that in Malaysia, probably it's the Asian population that sometimes we need a higher dose of FSH or HMG to stimulate the ovaries.
Interesting.
This question from Dr. Haris Hamzah to both speakers. I have a 38-year-old lady, recently amenorrheic, AMH of 24 nanomoles per liter, FSH of 18, LH of 12, has a good bilateral antral follicle count of, I would say, probably more than 8 millimeters. Not responsive to stimulation, unfortunately. What's your advice?
So my first question would be define not responsive. Sometimes we find that these patients may have been suppressed with birth control pills, for example, to allow for batching of cycles or programming of a cycle. And as a result, you need to actually wait for some time for that suppression to wear off. Sometimes you're too soon to cancel the cycle. So for example, the patient's been treated with 150 units of Menopur continuously, and there's been little budging of the estradiol, right? It's less than 5, or there's been no follicular growth after 5 days. I would say keep going for at least another 2 to 3 days to see what happens. If the patient, remind me, does she have regular cycles or irregular cycles?
She is amenorrheic.
Amenorrheic.
No periods.
So
yeah,
what I find frequently is that in these amenorrheic patients, people use a birth control pill as almost a way to jumpstart a cycle. without realizing the risk of the suppression. And as a result, you might actually be better off for this patient of just doing the random start with the 150 units of HMG or of Metapure, or even doing 150 units of HPHMG in addition to 150 milligrams of clomiphene citrate orally, allowing you to try to capitalize upon endogenous and exogenous hormones for this patient.
Yeah, I would also advise to try to use increased dose gonadotropins to trigger ovarian response. It may well be that this patient may have gonadotropin-resistant ovary syndrome, and this could be an acquired syndrome. So we have come across patients like these who used to have normal ovarian function until a certain point in their life, and then all of a sudden become amenorrheic, increased FSH levels, endogenous FSH levels, but normal ultrasound scan, normal antral follicle count. And in these patients, we perform antibody testing. So some of these patients may have acquired ovarian resistance as a result of ovarian antibodies. But it's very hard to have a precise diagnosis in these patients. Some of these patients have anti-thyroid antibodies or anti-adrenal antibodies, and this may be a hint for the diagnosis, because some of these patients have just an acquired autoimmune disorder, and as a result of that, the FSH receptor just doesn't function anymore. But it's very hard to treat. We have tried corticosteroids in these patients to try to mitigate the autoimmune problem, and this may help. So give her corticosteroids for a couple of weeks, and then try to start ovarian stimulation. That could be an option. And as a last resort, you could try IVM.
Yes. Following to that, yes. Thank you, Dr. Harris. Yes. Following that to that answer, there's one question here about IVM. Is there a steep learning curve or the need for a big upgrade of the lab to offer IVM?
Okay, so probably not. So probably it sounds more difficult than it really is. For the majority of reproductive endocrinology and IVF doctors, it only takes around 10 IVM egg retrievals before you can say that you're proficient and that you can perform egg retrievals from small antral follicles. It's just a matter of having a good ultrasound scan machine during the egg retrievals, and try to get some training on good patients, selected patients who are not obese and who have a very high number of antral follicles. For the lab, the most difficult part is the search for the small cumulus oocyte complexes. So it may take a while for the embryologists to get comfortable with identification of COCs, but then again, this is not very difficult. We are in the process of producing a video publication that will be published in Fertility and Sterility any of the upcoming months, to show what we are actually doing in the lab and in the OR.
I'll just add one question actually to you, Michel. Would you just care to share what you changed, because I know that you guys do, for the actual retrieval itself, both the needle that you use and the pressure settings for the retrieval?
Yes, so we use the 17 gauge Cook needle, and we reduce the pressure to 70 millimeter mercury. So I understand that you work at CCRM, and Bill Schoolcraft in CCRM Denver is one of is an advocate of IVM, and I know that in his lab they are actually performing very good IVM practices with good results.
Yeah, so it is I am part of the CCRM network, and I oversee the New York office, but it is one of the tools that is also in our armamentarium for treating those most challenging patients. And it's a wonderful tool.
Definitely.
There's another question here. I think it's for Prof. Because it's regarding Recovel. Do you follow Recovel algorithm strictly, and do you have minimal dosage despite what the AMH or the weight is?
Okay, so I understand that this is a question for me.
Yeah.
We use the algorithm for naive patients, although I have to say that in low responders, we do not use the algorithm because the algorithm stipulates that the maximal dose is 12 micrograms per day, which is too low for a low responder. So in low responders, we even in naive low responders, we go up to 24 micrograms per day, which is not in line with the algorithm. So I would say algorithm, yes, for normal responders, but not for low responders.
Okay. This is probably the last question. It's a bit long. I have to read it for you. And I put it for both of you. This doctor had a PCO patient with cancer endometrium, treated with generic agonist for 7 months and letrozole for 6 months. And when she did not respond to Megax. When letrozole was stopped, her FSH was 10, but LH was less than 1. And she also lost 20 kilograms over a year. Her AFC previously was 28 and now it's 9 after stopping letrozole. She failed to respond to HMG 300 units and cycle had to be cancelled. Any thoughts on what to do next? It's a bit tricky, isn't it?
I guess my first question would be, why was there such a long duration of agonist? And why did you give the Lupron for so long? One of the most powerful medications that we have to offer our patients is what I colloquially call the tincture of time. And the tincture of time, meaning sometimes we just have to wait a little while for things to calm down and come back. And so I would say is that before giving up hope on this patient, I would potentially say wait a month or two and then reattempt the stimulation. I would do monophasic again. I actually subscribe to using lower doses or doing potentially a mini stim on her to see even if you can get a small cohort of oocytes just to grow, but hopefully a good cohort. So again, I would potentially just even, I'd wait a few months, try again with, if she's not getting any periods, do a random start. I would use clomiphene citrate as an adjuvant, and then I would add the addition of Menopur as the mono agent along the way. The one thing I'll share is that in the United States, there is a very popular trend of using human growth hormone in challenging patients. In the state of New York, where I live and practice, we are actually unable to use human growth hormone as one of our adjuvants for our treatment protocols. So I do not use it for me, but other states in America can do it, such as where Bill Schoolcraft is in Colorado or in California or Massachusetts, other states. With that said, in New York, more IVF is done in New York than any other place in America, and none of us use human growth hormone. So if it truly was making a big difference in outcomes, we'd be losing all of our patients to either neighboring states, and we're not. But I have seen in these scenarios where we have these most challenging stimulatory patients, people have deployed almost empiric human growth hormone, not because there's any evidence that there's human growth hormone deficiency as a result of taking a prolonged agonist, but I have seen it done.
Okay. Well, the discussion has been very, very interesting, but I think because of interest of time, I have to stop the discussion now. I would like to extend my sincere thanks to our speakers. Special appreciation also to the co-organizer, Ferring, and gratitude to all participants for your time and attention tonight. Kindly remember to complete the post-webinar surveys after this, and we look forward to welcome you again in our future programs. I would like also to post this post-webinar survey on the chat box so that probably you can assess it if you can't assess it after this. But please do answer the post-webinar survey after this chat. And with that, I would like to thank again Dr. Brian Levine for your time, and also Prof. Michel for your time. I know you're in the Alps somewhere. Do enjoy your vacation. And we hope to see you probably one day in Malaysia when you do come physically and give us an excellent talk again here physically in Malaysia. With that, I bid everyone farewell. Thank you. Terima kasih. Good night, everyone. Good morning or good afternoon, wherever you are.
Thank you. Good night,
Thank you.
everyone. Bye.
Good night, good morning, good afternoon, and thank you.